So today we're going to talk about a presentation of idiopathic facial nerve paralysis and how we do a neurological examination to determine that this is the most likely cause and what is the management. Facial nerve paralysis is one of the most common neurological presentations in the dog, and the most common diagnosis is idiopathic facial nerve paralysis, which is often referred to as Bell's palsy in the dog. And this is a good example of how a good neurological examination can be the key to good management and, importantly, good prognostication. So to understand this, we need to know, first of all, about the anatomy. What does the facial nerve do? Well, it's the seventh cranial nerve, and it's probably its most well-known function is that it's motor to the facial muscles. So that is the muscles that control movement of the nose, the lips, the ears, and the eyelids. So really all of the muscles that you can see here in red and also the ones in grey. It's sensory to the external ear canal right down the bottom, and it gives taste to the rostral, that's to say towards the tip, 2/3 of the tongue. And it provides parasympathetic supply to the lacrimal gland, so tears, and the mandibular and the sublingual salivary gland. And of course, it's one of the cranial nerves coming off, when you look at them in sequence, number 7, which is here under coming from the base of the brainstem. And at a cross section here at the level of the tympanic bulla, this is the tympanic bulla here, this is an MRI scan. The facial nerve nuclei is ventral within the medulla oblongata, and the facial nerve leaves the skull via the foramen, which is called the internal acoustic meatus, and it's accompanied by the vestibular and the cochlear nerve. And in fact, they're enclosed in a common sheath of dura, which is quite important in that sometimes we see those nerves affected together. So how do we assess facial nerve function? Well, we actually have to use a number of tests because there isn't one single test which is uniformly useful. You have to take into account the results of many testing, and that is the palpebral reflex and the corneal reflex. We can see here facial sensation, tickling the cat, and we can see twitching of the skin. Tickling the ears there and see twitching of the skin. We can also see closure of the eyelids. We are also looking at the menace response. So that's closing of the eye in direct response to a threat, and also facial symmetry. So signs of facial paralysis, we have an inability to move the lips, drooping of the lip, and loss of movement of the eye or the ear of the eyelid. And that's often what an owner will notice and present you with the animal for. Incomplete closure of the eyelids can lead to corneal ulcers, especially in brachycephalic dogs, which will have an insufficient tear film anyway. They may drool or drop food or have messy drinking. You may notice saliva in the water bowl. And this may also be the thing that the owner has noticed. Loss of the palpebral reflex, so they fail to close their eye when the skin is touched. The ear may droop. They may have dry eye. They may have loss of taste, which is not usually observed with animals, but might be a contributing factor to anorexia. And they can get food trapped in the cheek because the buccal muscles help push the food from the outside part of the mouth, the cheek muscles, into the central part of the mouth for swallowing. And if food is trapped there on the paralyzed side, it can actually lead to quite a lot of dental problems, which we will talk about later. So we're going to talk about one case that was presented to me with a facial nerve paralysis, and that is the very adorable Molly, who you see pictured here. She's a 7-year-old toy poodle, and she was presented to me after she had a 10-day history of not blinking on her left side, and her primary vet had already diagnosed her with a left facial nerve paralysis. It should be said, mainly because you may notice that Molly has some other things going on, that she has an 18-month history of well-controlled diabetes mellitus. So this is completely unrelated, except this did cause some diabetic cataracts, and she has had surgery for those, and that means that her vision, although really very good post-surgical management isn't quite 20/20. You may also notice her endocrine hair loss, and this isn't classical Cushing syndrome, or is it hypothyroidism? And she's been well tested for that, so please don't comment about that. That's all in hand and not related to the problem that we're going to see. So our first step in Molly's case is to examine the cranial nerves. So here you see, first of all, doing a menace response on the left, which was negative, and we can see that she can close her eye on the right. So then we assess facial sensation plus the ability to blink, and we can see a good palpebral reflex on the right side and then absent on the left. Now, notice when I do that, it's quite an important observation. Because she still has sensation, she's able to retract that eye backwards, and you see that characteristic third eyelid flick, which is very characteristic for facial nerve paralysis. We've got some good sensation down the base of her ear there, which is the facial nerve. And we can also see that she has sensation also on the left side. Now, I want to look at her lips here. And on this side, that's a bit difficult to see. It's very floppy, and we have a little bit of trapped food in that side, whereas the other side, it's much tighter, and we also don't get the dribbling of saliva down that side. I would also be doing a jaw tone and gag at that point. So just looking on at the papillary light reflex, and we can see here that we have slightly dilated pupils because of the cataracts, but we do have a PLR that is direct and consensual, and we also have good movement of those eyes and normal ocular vestibular response. So in this dog, we just have a left-sided facial nerve paralysis. Now, a very common confusion is the difference between trigeminal loss and facial loss. So we're now going to look at a video of a cat with a trigeminal problem. So this is a cat with a right-sided trigeminal lesion, absence of facial sensation, but the facial nerve is intact. Now, how do we tell the difference when we're looking at reflexes like the palpebral reflex, which is sensory through the trigeminal and motor through the facial? Take a look. So with this cat here, the absence of any facial movement, but that is because the cat has an absence of sensation. When we go right the way deep down into the ear, where the facial nerve has sensation, we do see that flick of the ear. So we can tell that this cat does have facial movement. And also we would do other tests such as facial symmetry and menace response. So next thing that we want to look at is her mental status, her posture and her gait. Now, why is this important? Well, it's so important because we need to tell from a prognostic point of view the difference between a central problem in the brainstem and a peripheral problem with the nerve. And that is because problems coming off with the nerve would be typical for idiopathic facial nerve paralysis and possibly an inner ear, middle ear infection. But problems with the brainstem would result not just in a problem with the facial nerve, but also a problem with all the other important pathways going through this region. So it's impossible to damage the medulla oblongata without damaging mentation, because we have the reticular activating system there, without damaging those motor tracts going down to the limbs, giving us weakness, and without affecting the proprioception coming up, relaying through the brainstem up to the sensory cortex. And it would also be likely to be affecting other cranial nerves. And so we need to look at the rest of the neurological exam to determine that Molly just has a facial nerve paralysis. So we want to look at her mental status. Is she bright and interactive? Because obtundation would suggest brainstem disease. Is her posture normal? Because a head tilt would suggest vestibular disease. And is her gait normal? Because the vestibular nerve, which is for balance, is exiting that internal acoustic meatus with the facial nerve. So it's not unusual for them both to be affected. But also, if she had a proprioceptive rather than a vestibular ataxia, then that could suggest brainstem disease. So take a look at Molly walking now, and what do you think? Do you think she looks bright, active, interested in her surroundings? I think you agree that this is a dog with a very normal looking mentation.
Circles, please.
Getting a dog to circle is a good way to pick up subtle balance problems and proprioceptive deficits. And as you see here, Molly is able to circle very well. And she crosses her legs when she turns. So now we're going to go into a more detailed examination of her postural responses. We want to assess her for weakness and for proprioception. So first of all, we're going to knuckle over a paw. Now notice where my hands are here. My hands are fully supporting her weight because proprioception is sensation. And we want to take away any influence from her having to have strength to pick up her paws. So we want to fully support her weight so that the only information is that her paw is in an abnormal position. And we can see here, and I'm fully supporting her weight there, and I knuckle over and she rapidly corrects. So Molly has normal correction of her feet here. In fact, she won't even let me turn over her feet because she would find that too abnormal. It's not the only test that we use for proprioception. We also use hemi-walking, which I think Molly is a little bit confused about at the moment. And what we're looking for to here is an absence of knuckling, and we do that. And then we have hopping. As soon as the shoulder is over, no longer over the carpus, then there should be a hop. And this is absolutely completely normal hopping in little moles here. So normal postural reactions for Molly here. That mean that brainstem disease is extremely unlikely. And that's really the main thing that we need to do when assessing a patient with facial nerve paralysis. We need to establish that they have no evidence of other cranial nerve involvement or that they have evidence of brainstem disease. Now, at this stage, we could rule out some other common sort of metabolic diseases that might be associated with facial nerve paralysis. And we could advise the client that this is most likely to be idiopathic and perhaps recheck Molly's neurological status in a couple of weeks. We could do spinal reflexes, and we did in the case of Molly because she is diabetic, so she could have a diabetic neuropathy, but these were completely normal. And the most useful reflex, that is lightly pinching the toe to get a withdrawal reflex, wanting to see flexion of all of the joints. So our conclusion when we looked at Molly was that she had a left facial nerve paralysis. She had minor visual and pupillary light deficits relating to the previous cataracts. But these were really very, very minor. You wouldn't know that she functions visually completely normally now. Her mental status is normal, her gait is normal, her posture is normal, no evidence of a head tilt, and she had normal postural reactions. So our conclusion is that she has a peripheral facial paralysis. So what are our differentials in this point? I just want to point out here, this is a CT scan at the level of the tympanic bulla, which is here, the middle ear. That's the external ear canal. And this is the trappings of the inner ear here. And this is the middle ear. These are the bones of the inner ear here. And this is the area of the facial nerve. It sort of comes out through into the sort of temporal bone area, which is the facial canal and temporal bone, and then does a very acute right turn. But it's sort of caudal to the stapes, and the tendon of the stapes, the stapedius muscle, emerges from the same opening in the facial canal. So this is the sort of area that you're looking at if you're doing imaging. So what are our differentials? By far the most important differential is idiopathic. Then we have otitis media, and I would have to say that if it is a dog that doesn't have a history of inner ear disease, then this is not such a likely differential. So if you're seeing a dog for the first time with a facial nerve paralysis and you look in the ears, you do an oroscopic examination and the ears look absolutely clean, then it's pretty unlikely that it would spontaneously get an otitis media. It's not impossible, but it's pretty unlikely. A young cat, on the other hand, you have to be aware that they can get polyps, which means the external ear canal can look very normal, and the polyp can be obstructing the middle ear, and they can get an infection that way. Hypothyroidism is an often quoted cause of facial nerve paralysis, but it really is overstated. And that's because some historical papers went on about it, but they have rather dubious diagnostic testing. Just taking a T4, dogs were undoubtedly had a euthyroid 6 syndrome, and you really need to do more vigorous diagnostic testing with at least a TSH and probably a 3T4. We can see non-neoplastic masses such as cholesteoma of the middle ear causing a facial nerve paralysis. Again, these are dogs usually with a chronic history of ear disease. And then very rarely we can have neoplasia causing a peripheral facial nerve disease. So carotid body paragangliomas and tumours involving the nerve roots. So what causes idiopathic facial nerve paralysis? Well, idiopathic is a term that in neurology is referred to a syndrome that we recognize, but when we do imaging, we don't see structural problems, although that's not quite true with facial nerve paralysis. It's thought to be genetic factors, so we are much more likely to see it in middle-aged Staffordshire Bull Terriers, Boxers, and any type of Spaniels. In humans, having Bell's palsy, viral triggers, especially herpes simplex, has been suggested. The other thing to bear in mind is the other side may become affected. So they may have one side affected, then several months later, the other side can become affected. And some dogs may have associated vestibular signs, especially the Spaniels. And the Staffordshire Bull Terriers and Boxers. And this is probably because the nerves share a dural sheath. My theory is that the facial nerve is inflamed, and then because it's tight within that dural sheath, the vestibular nerve becomes affected. And typically the vestibular nerve and having signs of vestibular disease resolves in a few days, and they're left with the facial nerve paralysis. So what other tests are we going to do? Well, we will do an otoscopic examination for signs of otitis media or externa. We do want to evaluate tear production via a Schirmer tear test. And then we want to monitor the neurological exam. And if things remain stable, then idiopathic facial nerve paralysis is much more likely. And some caregivers may choose for having their dog have an MRI scan. And this indeed was the case with Molly, and why she was referred to me. And so we need to know our facial nerve anatomy. And as I said before, we're looking in the sort of ventral medulla, and actually slices caudal to this is where the facial nerve is more. We need to look in this area where the facial nerve is leaving the skull through the internal acoustic meatus. And then the facial nerve enters the facial canal. And if you think back to that CT image I showed you, you may see a very subtle hyperintensity in the area of the left facial nerve in the facial canal. And this is Molly's image here. And I think you could agree, you see kind of the facial nerve there a little bit better. You may need to give me the benefit of the doubt here, but you may see that just a little bit more clearly than you can see the other side. But you can see you're looking for really quite subtle things. And again, this may be the facial nerve a little bit more hyper intense as it makes that right-handed or acute angled turn as it comes through the tympanic bulla. So this is the T2 weighted image, and this is a T1 weighted images, and this is a contrast enhanced image. And again, it looks more subtly enhanced on this side compared to that side. Sometimes dorsal images can be a little bit more useful in this instance. And so this is the left side. And again, you can just see it slightly brighter compared to the right side. Maybe a little bit more convinced there, but it is subtle. And that's the level at which that dorsal image has been taken. And that sort of captures that right angle turn as it tracks caudally towards the styomastoid foramen. And in some cases, in idiopathic facial nerve paralysis, you can see some enhancement in the branch of the facial nerve that is going to the lacrimal gland. It's the major protrusal nerve, and that is occurring sort of more rostrally. Now, this shows a Schirmer tear test. You can see one side here is less than the other. This wasn't Molly. And parasympathetic involvement is sometimes affected in idiopathic Bell's palsy, but I have to point out it's rarely affected in other peripheral facial nerve disease, and that's because that really is quite cranial. So it would be extremely unusual to see parasympathetic involvement, in my experience, in an otitis media. So if you are seeing a neurogenic dry eye, then you really should consider central disease, in particular check out the trigeminal function, because after this level, the parasympathetic supply to the lacrimal gland actually travels with the trigeminal nerve. And so in my experience, you're more likely to see a neurogenic dry eye with trigeminal nerve problems than you are with facial nerve problems. Now, another handy thing to look at on the MRI scan is the caudal digastric muscle, which is innervated by the facial nerve. And the way to do this is to take a transverse section at the level of the fourth ventricle. This was really nicely detailed in this paper here, which was published in Veterinary Radiology. And you can see here at the level that in Molly's images here that her digastric muscle here and here, this is T1 weighted and this is T2 weighted, is much smaller on this side compared to this side here and here. And on T1 weighted images, there's hyperintensity, and also in T2 weighted images on hyperintensity. And they say that dogs with this finding are much more likely to have persistent facial nerve paralysis 3 months after onset. So you would say that if you saw this, then it's much more likely that the dog is going to be persistently affected. And what does that look like? Well, with chronic facial nerve paralysis, you often find that the muscle becomes contracted. And so the face has a different appearance. It was very floppy before, but chronically it becomes contracted. It's probably due to muscle atrophy and the contraction. And you can see here actually in this little guy that the palpebral aperture becomes smaller and the lip actually curls up a little bit. So how do we manage it? Well, it's very important to provide ocular lubrication because we have increased exposure because of the failure to close the eyelid. And a closing of the eye is an active process, so the dog may sleep with an open eye, and they also may have reduced tearing. So we have to be very careful of that because we don't want to add more problems. We do need to pay attention to oral care because there's a likelihood of food getting caught around teeth. So we need to pay attention to that and if ideally, brush the dog's teeth, or at least kind of flush the mouth out, perhaps with a dog-friendly mouthwash. And bear in mind that drooling may cause a wet eczema, especially if you've got a lot of fur around here. The prognosis overall for the dog is good, because idiopathic facial nerve paralysis is a relatively benign disease. However, facial nerve function may take years to return or not return at all. And so they may be left with that as a permanent paralysis. Is there any other treatment you can do? Well, in humans, you may be managed with steroids. And there was a Cochrane study, which is basically looking at the best evidence. And they found that high-dose steroids within 72 hours were more likely to have a rapid and more complete return of facial nerve function. What does that mean? It was 1 milligram per kilogram of prednisolone a day for 6 days, then withdrawn over 4 days. Please note, not months and months and months worth of steroids here. But in humans, they also give antiviral drugs because viral causes are thought to be the most important, which has not been shown in dogs. And it also shows that it's been more than 72 hours, then corticosteroids are less likely to be effective. So there is an argument here that if you are wanting to give steroids, that perhaps you should have an early referral and an MRI. And if I see an animal that's been more than 72 hours, then I do not give the steroids. I don't just throw drugs at these dogs, especially not steroids, because the risk outweighs the possible benefit. And that's because steroids will also mask diseases. So if you're thinking, oh, well, just give steroids because if it's a tumor or inflammatory disease, that will help. No, it won't help, because it will help temporarily. And the owner will be freed up by the fact that they may be improved. But then the disease will just come back, because a tumor or inflammatory disease won't be cured by steroids alone. And so my advice to you is that repeated neurological exam is going to be more useful than throwing steroids at the dog. So don't give willy-nilly, as we say here in Britain. It will interfere or delay with diagnostics, and it may even change the prognosis. And my general experience with giving steroids is that sometimes you can see an improvement with dogs, but sometimes you see a very temporary improvement and then the signs come back. And I also don't give more than I give the same protocol as with humans. I don't give them extendedly. Thank you very much.